So good afternoon. Welcome to a new webinar on pediatric cataracts. This time focused on different aspects of this pathology. Today we are lucky to have 6 experts, European experts, led by Marta Morales. She is of the Pediatric Ophthalmology Department at San Diego Hospital, to update us on different aspects of pediatric cataracts. We will start with an introduction on what we know so far about pediatric cataracts. We will discuss about the diseases related to pediatric cataracts and which test has to be asked to rule them out. Then a surgical point of intraocular lenses and the point of view of the patients on the contact lenses. I hope it will be of interest of all of you. We will have time at the end of the webinar to answer some questions, but you can post them in the chat during the webinar. And I give the floor to María Nieves, that is a pediatric ophthalmologist that works here with me at Zapat Hospital in Madrid, and that has been trained at the Great Ormond and Royal London Hospitals. Thank you, María Nieves, for starting this webinar.
Good afternoon. As Susana said, I'm going to do a brief presentation that will be a brief summary of what we know so far about pediatric cataract, and it's an introduction to the very interesting presentations that my colleagues are going to make this afternoon. The prevalence of congenital cataracts is between 2 to 13 every 10,000 births. But not all the children born with cataract will need early surgery. And the need for treatment varies from a dense cataract present at birth that will need surgery usually during the first few weeks of life, a partial cataract present at birth that might need a close follow-up in the clinic to check for visual development, and a progressive cataract that might need surgery but later during childhood. And with congenital cataract, an early identification, diagnosis and treatment are key for a good outcome. That's why most countries have their screening protocols. In Spain, this screening protocol is in charge of the pediatrician. They should check the read reflex within the first 48 hours of life before the infant leaves the hospital, and then again at 2 weeks and at 4 weeks in the scheduled follow-ups appointment with the pediatricians. Even though the reality in our center is that 80% of the cases, the ones that have raised the concern about the cataract or about the eye abnormality, are the parents before the pediatrician realizes. This is important because we know that optimal surgical results require a very early referral and intervention. In developed countries, the majority of bilateral cataracts are genetic. But we cannot forget about other etiologies that include trauma, maternal infections, intrauterine chemical and drug exposure, or metabolic. And some of these etiologies will be discussed later in other presentations. In our hospital, we order genetic testing in all bilateral cases and unilateral if there is a positive family history for congenital cataract. And when we suspect that the children has a syndromic phenotype or there are other health issues with the infant, we refer him to the pediatricians and the clinical geneticist. And for unilateral cases with no family history, we don't do further testing, if there are no other health issues, of course. The genetic of congenital cataract is every day more important. Congenital cataract were the first disease with autosomal dominant inheritance mapped in human. Non-syndromic congenital cataract usually have complete penetrance, with autosomical dominant cataract being the more common, and the expressivity is highly variable. So the same mutation within an affected family may give different phenotype. And also, the same type of cataract can be caused by mutations in different loci, making it a polygenic disease. 71 losses has been assigned to 56 cataract-causing genes and have been identified nowadays. And the most frequent implicated genes are those for crystallines, developmental or transcription factor, connexins, membrane proteins and transporter, genes involved in metabolism, and intermediate filament and chaperone proteins. When we order a genetic test, the first thing we do is a cataract panel. The panel includes all the genes known for causing cataracts, congenital cataracts. If the genetic panel is negative, we don't find the cause of the cataract with this test, but we think the cataract is most likely genetic, we can order a complete exome. This will analyze all the coding DNA. And a complete genome will analyze the whole DNA, but nowadays this is mostly reserved for research. Now I'm going to briefly present our results in the genetic of congenital cataract. This is the first study, and what we did is that we used our cataract panel that at that time included 39 genes, and the mutation detection rate was 49%. Almost all our mutations were autosomical dominant, and mutation in crystalline genes were found in 30% of the probants. As a second study, we analyzed the results of the complete exome in patients that have a previous negative panel, and we achieved a new diagnosis in 10% of the families. And in 35% of the families, we found candidate genes that, due to the relationship with the pathological process of the disease, might be confirmed or maybe ruled out in the future. But during years, the big debate about congenital cataracts was whether or not implanting an intraocular lens in an infant. Luckily for us, we have now strong evidence of what we should do. We have two major studies. The EYE, that was from the United States, was a randomized clinical trial, and their results showed that there were no difference in short-term and long-term visual acuity. But there was an increased number of interventions in patients with lens implantation, and an increased risk of glaucoma in unilateral cataract that was not associated with the lens implantation. The other study is the IOL-2 from the UK, which is a multi-center cohort study, and their results showed that lens implantation slightly improved the visual acuity, but only for bilateral cases. There was an increased risk of intervention in patients with lens implantation, and the lens did not decrease the likelihood of secondary glaucoma. The main conclusion that we should learn from these two studies are that primary IOL implantation in children under 2 years old does not confer improved visual outcome over aphakic contact lenses. The intraocular lens have not been found to confer protection from the risk of secondary glaucoma, and the visual axis reopacification is much more common and earlier following surgery with intraocular lens in children under 2 years versus leaving them in aphakia. And another question is, when is the optimal time to operate in an infant? We need to balance the risk of the general anesthesia and the secondary glaucoma when operating early with the risk of irreversible deprivation of amblyopia when operating late. Nowadays, most surgeons agree that for dense unilateral cataract, surgery should be performed between 6 and 8 weeks of age, and for dense bilateral cataract, surgery should be performed between 8 and 10 weeks of age. And after the surgery, we will need to follow our patient for the rest of his childhood. We need to check his visual development, looking for amblyopia, helping with the contact lens fitting, looking for strabismus or nystagmus. And also, we need to be vigilant of the complications. Early complications that include infections or correctopia, and late complications that can appear even years after the surgery, like retinal detachment, glaucoma, or reopacification. This is the follow-up protocol that we do in our center. We see a child the next day after the surgery just to make sure there is no early complication, and then in 2 to 3 weeks to see how the inflammation is settling and to check for the early complications. After that, we do refraction in a month after the surgery, and if everything is fine, we start the 3, 6, or yearly follow-up as the child is growing to check the vision, to check refraction, and to check the appearance of late complications. But one of the challenges after the surgery is amblyopia. It is important to correct any refractive error as soon as possible after the surgery to provide a focused retinal image and enhance visual development. The treatment for amblyopia in unilateral cataracts is much more difficult because of the unilateral stimulus deprivation, the high anisometropia, the absence of accommodations, and the strabismus. And the IETS study found that occlusion therapy of 4 hours or more daily over the first 4 years led to better visual outcomes than occlusion less than 2 hours. And well, this is what I wanted to say. Thank you very much.
Next presentation would be on metabolic, genetic, and neurological disorders related to pediatric cataracts by Marta Morales, that is the chief of San Jandeneu Pediatric Ophthalmology Department. Thank you, Marta.
Good afternoon. It's a pleasure to share this webinar about pediatric cataracts. Since next generation arose in medicine as a quicker and easier method of studying clinical exomes, genetic in medicine made a big change. In the field of pediatric cataracts, a group in Manchester was the first of using a pediatric cataract panel composed by 115 genes. They reported 175% rate of putative genetic cause in their group of patients, up to 85% when the cataracts were non-syndromic. The next generation sequencing targeted panel in cataracts, if quickly done, avoids other blood test studies and long and tedious pediatric and neurologist visits to reach the etiology of the cataracts. Currently, it's been using worldwide, but we lack a large cohort of patients. In the literature, we found not very much papers about etiology of pediatric cataracts, and we found one paper of the Australian group with a retrospective review along 25 years with 421 patients with pediatric cataracts. Of 342 without a family history, 60% of them had been recognized of having a systemic disease. And you can see here the syndromes most frequent, that was Down syndrome, rubella, periopathy, aniridia, juvenile chronic arthritis, diabetes, galactosemia, and the list that you can see. In the Swiss cohort, 37 patients from 25 families with pediatric cataracts during 1 year and a half from 2019, from January to July 2020, they had 80% of putative diagnosis rate, and they found 30% of syndromic cataracts with BCOR gene in 2 cases, Nance-Horan syndrome in 2 cases, and COL4A1 syndrome also in 2 cases. Therefore, the aim of this study, of this talk, is raising awareness about neurological and genetic disorders in pediatric cataracts, share research findings, and discuss clinical implication. Non-syndromic pediatric cataracts can be caused by a gene that affects only the lens, like crystalline genes, MIP, gap junction genes, or by genes that affect the anterior segment, like PAXIS, or the posterior segment, like Stickler, or other myopia and vitreoretinal degenerative. Unilateral cataracts are known to be caused mainly by posterior fetal vasculature. So they used to be non-syndromic, and only small cases are syndromic. And this account for oculofaciocardiodental syndrome, Aicardi syndrome, or infections during pregnancy. In 75% of bilateral cataracts, the genes are non-syndromic, and only 30% of them are syndromic cataracts. So the etiology of the cataracts of bilateral pediatric cataracts are the list that you can see here. Traumatic, secondary to systemic treatments like in corticotherapy, chemotherapy, or radiotherapy, secondary to ocular surgery, well known in some systemic diseases, like, for example, in Down, as you have seen, in rheumatoid arthritis, myotomic dystrophy, neurofibromatosis. It can also be caused by pregnancy infection, but also bilateral cataracts can be the first sign of a disease. The genetic etiology of bilateral pediatric cataracts is really complex because there is a high genetic heterogeneity. This is the presence of a variety of genetic defects which cause the same disease, often due to mutation at a different loci in the same gene. We can find novel mutations which can be difficult to interpret. We can find recurrent variations. There is a difficult genotype-phenotype correlation. It's really difficult in sporadic cases and more difficult in syndromic cataracts. When we face a child with a bilateral cataracts, we perform a medical exam and ophthalmological examination of the anterior pole, posterior pole, the morphology of the cataract, and we have this. And if we have the suspicion of a syndrome, we send the child to a pediatrician or to the neurology, and we also take a family history. In the same first visit, we do a blood test for clinical exome by next generation sequencing in the targeted gene panel, and if the child, we have the suspicion that he has a syndrome, we make the human phenotype ontology with all the features that we see about the syndrome. If we have a putative gene etiology, we perform the blood test to the parents, and we send the child and the family to the genetics counselor. And these are our results. Of 66 patients that had been gone to surgery for bilateral pediatric cataracts during the period of 2016 to 2021, we find putative gene diagnosis in 64% of them. We found 38% of genes that affect only the eye, and 26% of the genes that were the cause of a general syndrome. We found 23% of patients to be negative, we didn't find any gene causing the cataract, and 30% of the patients were SWAN. This is a syndrome. This is a syndrome without a name. So it's a child that after having done all the tests, all the gene tests that we have, we don't find a result, but we know that that the child has a syndrome for all the features that we can see. So counting the positive syndrome and the SWAN syndrome, we find general or syndromic cataract in 39% of all the patients. Non-syndromic cataracts can be caused by genes that affect only the lens, and you have here the list. Genes that affect also the posterior segment, like genes affecting the collagen or the retina or high myopia, or genes that affect the anterior segment. And here you can see the list of the patients with bilateral cataracts that were the first sign of a syndrome. And here you can see that we had cough syndrome, Wallow syndrome, mitochondrial complex 1 deficiency, nucleotide 10 syndrome. We find GAPO syndrome, 3 children with Hoover-Fong, 2 siblings and another child of another family with the same Hoover-Fong syndrome. We find a Nance-Oren syndrome, Pierpont syndrome, galactosemia, Peters, Hallermann-Streiff syndrome, Sanger syndrome, and Warburg-Mikro syndrome. 3 of them died very early. This is the children with a cough syndrome, the children with Sanger syndrome, and the child with mitochondrial complex deficiency syndrome. From all these 17 patients, most of them were neurologic, and we want to raise awareness about this. Only a few words of 3 or 4 syndromes that I think that you have to take in mind. This is Lowe syndrome, which is X-linked recessive. Lowe syndrome are children that are born with hypotonia and with bilateral cataracts. They used to develop glaucoma along life. In general, the cataracts are associated to meiosis. During life, they can do corneal keloids, and the female carriers have fine lens opacities or a posterior cataract. They also can have impaired intellectual development and renal tubular dysfunction. Nance-Oren syndrome is X-linked dominant. Males and females can be affected. It's quite frequent in bilateral cataracts. There is no genotype-phenotype correlation, and they are children with bilateral cataracts, microcornea. The female carriers can also have Y sutural cataracts. In 30% of them, we find developmental delay, and they have dental anomalies and large pointed and diverted ears. COL4A1 gives a syndrome with microangiopathy and leukoencephalopathy, or brain small vessels disease, and they are children with bilateral cataract and microcornea or microphthalmia, anterior segment dysgenesis, and they can have problems with strokes and aneurysm and angiopathy during all lives. So it's quite heavy to follow them. We have a child that her mother and her grandmother are really impaired because of strokes, with also bilateral congenital cataracts. And finally, cerebrotendinous xanthomatosis, you have to take in mind, because it is a deposition of cholesterol and cholesterol in multiple tissues, and you can prevent the child from having or delaying the systemic problems, because we have treatment for them. They are children with infantile cataracts, mild diarrhea, and convulsions, and tendon xanthomas if you don't treat them in advance. In conclusions, we can say that bilateral pediatric cataracts can be the guiding sign of systemic disease, most of them neurological. We have to outline the importance for referral centers for rare disease. We need a task force of geneticists, neurologists, pediatricians, patients associations, optometrists, and ophthalmologists to take care of these children. We need big collaborations with different specialized centers, and we have to know that it's a lifelong burden for families. And thank you very much.
Thank you, Marta. Next presentation is titled Back Index Implantations Results, presented by Dr. Luc Van Os, Senior Staff Member of the Antwerp University Hospital Belgium. I don't know if the pronunciation is right. That is an expert on pediatric cataract surgeries and inflammatory eye diseases. Thank you for participating.
Thank you very much. I'm very happy that I can here present some results about using the bag in the lens implant in pediatric cataract. So as Maria already expertly illustrated, we know that theoretically there would be an advantage of putting an IOL in an eye of a child when we operate it, because we will make them less dependent of contact lenses or glasses, which are not always to fit in children. And also when the eyes are aphakic and still very small, we're faced with very high refraction errors. So we are really forced to use contact lenses because the glasses will be impossible, especially in unilateral cataracts. Another advantage of putting an IOL in is that you would not need a secondary implantation, which is surgically not always as straightforward, because you can have synechiae between the iris and the capsule, you can have vitreous prolapse, etc. And also you need, for a secondary implantation, also again an extra anesthesia, and we also want to limit them as much the amount of anesthesias. However, as Maria said, both the IATS study and the IOL-2 study showed that there was much more visual axis reopacification, and thus also more reinterventions in the IOL groups compared to the aphakia groups. And they did not find a lot of improvement in visual acuity. So why do you develop visual axis opacification, and why is the bag in the lens such a good idea in this case? The visual axis reopacification, it comes to exist because the lens epithelial cells start to reproliferate. And the thing about these lens epithelial cells is that they can make their own scaffold, their own membrane that they can grow on. So even if you do an anterior vitrectomy, this will not completely prevent the chance of visual axis opacification, because the cells will just make their own membrane and grow on it. So when you have aphakia, you will have a good chance of capsular fusion, so the anterior capsule being stuck to the posterior capsule and locking the lens epithelial cells away, but you will not have a physical barrier on the edge, so there will still be escape routes for the lens epithelial cells to proliferate and cause visual axis opacification. When you put a lens in the bag, the IOL will keep the bag open, and the lens epithelial cells will stay in contact with the outside world, being the rest of the anterior chamber. And then also they will be in contact with cytokines and chemokines that are circulating there. And they will have even more stimulus to proliferate. And this is why you have much more visual axis opacification in these cases. If you do an optic capture, you again have a good chance of capsular fusion, but you still don't have a complete physical barrier on the edge. There will be parts where the lens blocks the lens epithelial cells, but there's other parts where they can still escape, especially at the position of the haptics, for example. The advantage of the bag in the lens technique is that you will have a full fusion of the anterior to the posterior capsule, and you have a 360-degree physical barrier by the lens itself. So the visual axis will remain clear, because the lens epithelial cells are really sequestered in a space around the lens, and they have no escape route anymore. Another advantage, especially in children, is that the lens is rather small. So the maximal diameter is 7.5 millimeters in the regular model. There's also a smaller model, the Mortrim 89D, which is 1 millimeter smaller, and which we only use in small babies with small eyes. Otherwise, we always prefer to use the normal size. Another advantage of this lens is that it's quite easy to exchange in case you have a high refractive error. So if the eye continues to grow more than you expect it to, you can actually relatively easily exchange this lens, because there is very little contact of the capsule with the IOL biomaterial. In a regular lens, there is a lot of contact, everything is sticky, so there's a lot of chances of damaging stuff. But here you only have a little bit of contact around the optic. Both anterior and posterior axes are fused, so if you flip the lens out, you will still have a nice ring that you can use to implant another lens with a different power. And also the capsular bag remains quite supple because there's less transformation of the lens epithelial cells, and they continue their task of nourishing the capsule and keeping it transparent and flexible. We also, and I think this is also a very big advantage in children, we see very little inflammation when we use this lens. So even in young children, we use just 1 week of topical steroids. We do not inject any steroids or give any systemic steroids, just 1 week of topical steroids 4 times a day. And then we also continue for non-steroidals for another month. There has been a study in adults also comparing a group of phaco-vitrectomies with bag in the lens or lens in the bag. And there they saw that only 2% in the bag in the lens group had synechia, whereas in the lens in the bag group, it was over 20%. This is an adult case, so it's not exactly applicable to children, but it reflects the low inflammation that we see with this technique. So here, just schematically, how the bag in the lens functions. So we make an anterior axis that we calibrate with a ring. I will show that in the next slide. And then after we've removed the lens matter, we will fill the anterior chamber with viscoelastic, not the capsular bag, because in children, the anterior hyaloid is very, very close to the posterior capsule. It's actually attached. So if you would fill the capsular bag, you would just push it even closer to the anterior hyaloid. Then we will make a puncture in the posterior capsule, and we do this always with a dragging technique. So we take the tip of a needle and we just slide the capsule sideways so that we don't puncture the anterior hyaloid accidentally. And then we inject viscoelastic to push the anterior hyaloid down. You push the ligament of Wigger, which is the attachment zone of the anterior hyaloid to the posterior capsule, and you push that far enough to the periphery so that you have enough space to accommodate the posterior haptics of the lens. And I will come back to that, why that is so important. After we fill the entire retrolental space, you can make the posterior capsular axis using the anterior axis as a guide and making it exactly the same size. And this is really important for the stability of the lens. And then once you've done that, it will look like this. Both anterior and posterior capsule will be close together, and then you can implant the lens. And the lens exists actually 2 ellipsoid haptics that surround a clear optic, of course. And there's always one longer haptic and one shorter haptic. And we will catch both capsules with the longer haptic. And then once we've done that, we will put the lens more horizontally and nudge it further in, like popping a button in a buttonhole. And then at a certain point, both capsules are nicely positioned in the peripheral groove around the optic of the lens. We always use a meiotic to prevent capture of the iris by the lens and close the incisions. So this is the ring that we use. It's a PIMA ring, so it's not super flexible, but you can insert it through a 1.2 millimeter incision. And it has a 4.8 outer millimeter and a 4.5 millimeter inner diameter, it's a little bit smaller than the ring we use when we use this technique in adults, because we want to correct a little bit for the elasticity of the capsule. When we use this technique, we don't do a standard anterior vitrectomy, only in cases where there's really an obvious dysgenesis of the anterior hyaloid, so where there's a lot of adhesion of the anterior hyaloid to the posterior capsule that cannot be dissected with the visco. And as I said already, it's very important to have the ligament of Wigger far back enough, because if you don't, there's a chance of reopacification. When you put a lens in a child's eye, it's also very important to realize what your target refraction will be. And as everybody, we will always aim for a residual hyperopia in young children, and we use the age of the child and the expected growth. But we also look at the actual length that the eye already has, and we look at the fellow eye, especially in cases of unilateral cataract as well. We started a few years implanting maximum 30 diopter powered lenses because we saw that if we went over in the young children, these were the children that went on to become quite myopic, whereas now with the 30 diopter lens, actually even with the babies, we end up with reasonably good refractive outcomes. And then if we put a 30 diopter lens in, we still have sometimes quite a high refractive error, and we do still need contact lenses for a short while because the eyes grow quickly, and from the moment the child's head is big enough to wear glasses, we usually switch to glasses because of the ease of it. This is just an illustration of the interface, of the anterior interface, which was normal in this case. So you see the dragging technique, we really use the tip of the needle to slide the capsule sideways, and you can see the anterior hyaloid on the OCT is starting to bulge forward a little bit. And here we use a 41 gauge subretinal needle on the viscoelastic. So it's a cohesive viscoelastic Helon that we use. We used to inject this under the posterior capsule and to push the anterior hyaloid down, which you can very nicely see in this video because the vitreous in this child was a little bit opaque. And the more we insist, you see, the larger we make the space behind the lens. And I will skip to the end of the video, because here at the end, you can very nicely see the bubble of viscoelastic behind the posterior capsule. So this is the edge of the anterior axis, and this is the edge of the bubble. And if you look here on the green axis, you see the anterior capsule there. You see the posterior capsule, which is pushed forward a little bit by the viscoelastic. And then here, this third line you see going down, that's the anterior hyaloid being pushed down. And so Weger's ligament, so the attachment between both posterior capsule and anterior hyaloid is here just right and almost under the iris. In lots of children, there's not a normal interface as here. So you see how here already there's a defect in the capsule. This is after we've taken the lens out. You see there's a little bit of vitreous even coming through it. And here in this video, it's easier to see the dragging technique. So really just appositioning the needle against the capsule and then sliding it sideways until you have a small hole. And again, here we use the 41 gauge needle. In older children, we usually just use the regular needle straight away, but the advantage is it's so narrow, you can very nicely go between the posterior capsule and the anterior hyaloid. Where I've injected a little bit, and you can see the bubble goes just to the edge of the hole, but at the level of the hole, there is an increased attachment of the hyaloid to the posterior capsule. But you can see when we insist, we can push the hole forward. So this means we are pushing the hyaloid back. And here I switch to the normal needle because it gives even a little bit more pressure. And you will see the attachment detaching here at the edge, and the bubble proceeding there. And then once you've covered the area of the anterior axis, you can start doing the posterior axis. And you can see here there's a very small strand of vitreous still attached at the area where there was the abnormal differentiation between the posterior capsule and the anterior hyaloid. And in this case, because it's just one strand, I just cut it with the scissors and not with the vitrectomy, because the rest of the anterior hyaloid is intact. So I can simply cut this one strand, push the rest of the vitreous down, because as in children, the vitreous is very compact. It's not as prone to prolapsing as it is in adults. We can continue making a posterior axis, add a little bit more visco, and then I injected the lens. You can see this is the posterior haptic. I push it below both capsules, and then using the pressure of the visco, we slide the lens a little bit sideways, and then I will use a hook to grab the other side, slide the lens sideways and down, and then you see that both capsules snapping in, and the lens is nicely positioned, and all of the lens epithelial cells are sequestered away. As I said, it's quite an easy lens to exchange. This is a child of 9 years old that had cataract surgery at 3 months of age and who became quite myopic. This was one of the children that received an IOL of over 30 diopters. We lift the lens out a little bit and we inject some viscoelastic behind. And this will push the anterior hyaloid back again and will push the lens forward into the anterior chamber. And then you can continue to cut the lens, take the pieces out, and implant a new lens. And here also there was some astigmatism, which we corrected with the toric variant. You can see the capsule here is a little bit more stiff, so it's a bit more difficult to position, but still it's lots easier than implanting something in a very fibrotic, in a bag that is completely fibrotic. And then we dial to have the right axis of the lens. So if you look at the results that are published in the literature, so we have published our early results, but there's also other groups from throughout Europe who have published their results. You see that there's always some level of visual axis opacification, although it's quite low. There's also some cases of IOP problems, so elevated IOP and or glaucoma. And you see the highest percentage here is in the publication from Alf Nyström from Gothenburg in Sweden. And they themselves actually saw that it was related to the age of the surgery, because they also did surgery in very young children there. And when they looked only at the older age group, so from 5 weeks old, they had a lower percentage of glaucoma. There are some groups that also report iris capture after surgery, and I will tell you also what we do to prevent that. So why does visual axis opacification occur? Because I explained to you it's not theoretically not possible. Well, it's not possible as long as your IOL is correctly placed. But when your IOL is not correctly placed, it can occur. So here the lens is correctly placed. You have the visco here. The ligament of Uyghur is far enough to the periphery, and the haptics have enough space, and the posterior capsule will stay in the groove. However, sometimes in young children, it's quite difficult to very well separate the anterior hyaloid from the posterior capsule, and the ligament of Uyghur will not be peripheral enough, like here. And then the posterior haptic will be a little bit curled backwards, and the anterior hyaloid will pull on the posterior capsule, and it can pull the posterior capsule out. And from that moment on, the lens epithelial cells can again escape and opacify. If this happens, we will do an anterior vitrectomy and suspend also the anterior hyaloid together with the posterior capsule and the anterior capsule in the groove. And with this technique if we have to do a redo with this technique, we did not have to do any second redo anymore. We developed 2 techniques to try and prevent this from happening. So to further dissect the ligament of Uyghur, the first is stretching of the capsule. So with 2 blunt instruments, like you would stretch an iris, a pupil, we stretch both capsules, and this also improves the detachment of both capsules the posterior capsule from the anterior hyaloid. And secondly, once the lens is implanted, we also turn the lens around so that the posterior haptic will also dissect the anterior hyaloid from posterior capsule. Regarding the capture of the iris in the IOL groove, here that's the reason why we use always a miotic at the end of the surgery to properly cover the haptics. And here it's also very important to ensure a perfect closure of your anterior chamber. If it's not perfectly closed, the pressure from the back will push the lens forward, and there's a higher chance of having an IOL capture. And in children, we all know they are much more prone to leaking, but actually with proper closure, we have not experienced any iris captures in the last 5 years at least. And as I said already, the sizing of the rhexis is crucial, because if they are too large, there is a risk of luxation of the IOL. If they're properly sized, so not larger than 5 millimeters, you're fine, and the lens will be stable, and there will not be a luxation. This was a recent publication showing a first experience with the bag in the lens in a very young age cohort. And there they saw that the eyes where they correctly implanted the lens did not have visual acuity, visual axis opacification, whereas the 6 eyes where they put the lens in only the anterior axis, which is fine for the stability of the lens, but all of these eyes developed visual axis opacification because there was nothing blocking the lens epithelial cells. I also looked, for the sake of this presentation, at our own data from the last 5 years for all of the children where we had a 1-year follow-up. So we had 82 children, 124 eyes. It's about half of the patients that we operated, because the other half are from abroad and we don't have easy access to the follow-up. And here we had 8 eyes of 8 children, of whom 3 were unilateral cases, where we had visual axis opacification, and this is 6.5% if you look at the entire group, but they all occurred between 4 to 14 months after the initial surgery. And all of these patients were younger than 1 year at the initial surgery. We did not have any cases of iris capture, as I already mentioned. And then if you look and you compare this with the data from the IATS and IOL under 2, you see what I said before in the literature. For the bag in the lens, you get 4.6 to 10% of free intervention needed. However, it's really important to properly position and detach Weger's ligament to an extent that is big enough. But all of these publications also include older patients. So that's why I looked at our own data from the last 5 years, and I looked at the 6 month and the children that were younger than 6 months. There we had a 14% re-intervention rate, and in the children under 2 years, it's at 13%. And if you compare that to both IOL under 2 and IATS, you will see that we're actually at the same level as the aphakia group, and actually even better than the aphakia for the unilateral eyes. So the re-intervention rate is certainly not higher than the aphakia groups from the IOL under 2 study, and neither was it higher than the aphakia group in the IATS study. And then if you look at glaucoma, there the numbers were very variable, but certainly also not higher than in the published series. And finally, I would just like to thank our entire team of orthoptists, nurses, pediatric ophthalmologists, and Professor Tassignon, my mentor, for all our work in treating these children. And thank you very much.
Great, team, thank you. So now let's put ourselves on the parents' skin, and let's know about the experience they have when the children have to use contact lens. From Riga, the Children's Clinical University Hospital in Riga, the presentation is going to be given by Dr Valeina and Dr Epnere. Thank you very much.
Dear ERN colleagues and all webinar listeners, the title of our presentation is Professional and Parental Experience with Contact Lens Correction from a Young Age. Only together we can get the best results of our patient treatment, closely cooperating and understanding each other as well as possible. Today, our team consists of 2 pediatric ophthalmologists, Dr. Sandra and Dr. Una, and 2 mothers of congenital cataract patients, Laumas Maza Baiba and Marta Maza Linda. Today, I will speak about the history of congenital cataract treatment in Latvia. Una will speak about professional experience with contact lens correction from a young age. Baiba and Linda will speak about parental experience with contact lens correction. Latvia is not a large country. In 2022, there were 1.8 million inhabitants. Only 15 to 20 patients with different types of congenital cataract are operated in Latvia in 1 year. I want to emphasize that it is a very small number in comparison to countries with larger population. Successful congenital cataract treatment is like a model of collaboration between pediatric ophthalmologists, cataract and vitreal surgeons, optometrists, orthoptists, vision therapists, and patients' parents. In Latvia, it means close cooperation between 3 different eye diseases clinics in 3 university hospitals. This slide depicts the history of congenital cataract treatment in Latvia. In 1967, the Child Vision Protection Center was established. It became the central institution for pediatric ophthalmology in Latvia. From 1973, all congenital cataract cases requiring surgery have been operated at the Children's University Hospital in Riga. In order to improve the surgical treatment outcomes and start implanting intraocular lenses, the Children's Eye Disease Clinic started a collaboration with the Latvian American Eye Center in 1995. Here you see our hospital guidelines for the congenital cataract surgical treatment and correction of aphakia in early age. Here you see that if the axial length of patient's eye is less than 90 millimeters and if the patient is younger than 12 months, at the time of cataract surgery, we choose to correct aphakia with contact lenses. That is all from me today. Now I give the floor to our clinic's pediatric ophthalmologist, Dr. Una Epnere, who has been making contact correction from early age children since 1997.
Hello, I am Dr. Una. As Dr. Sandra just now said, to reduce the risk of development of large myopic shift and to prevent deep amblyopia, our clinic performs congenital cataract surgeries at 6 to 8 weeks after birth and without intraocular lens placement. After the surgery, these patients need early optical correction. Due to the eyeball parameters, the extent of amblyopia is much higher compared to adults. Infants would need plus 25 dioptries or more. Optical glasses would be thick, heavy, and difficult to keep in correct position. For optimal results, contact lens correction is used, especially for cases of unilateral cataract. Once more, the main reason is to prevent deep amblyopia. For treating physician, after surgeries, my two main focus areas are, first and foremost, educate parents that surgery was only first step. The care needed for proper vision development will be continuous and ongoing process. I have to demonstrate, train, and encourage the parents to apply and to remove the contact lenses. This is typically a challenging process. The second important task is to determine the necessary eye parameters for contact lens. Refraction, horizontal visible iris diameter, and keratometry measurements are typically performed at the time of surgery using handheld autorefractive keratometer. Precise measurements are not always possible, so we use fitting guidelines. 1 week after surgery, we insert the first contact lenses and then assess refraction, usually by retinoscopy. Remember, add plus 3 dioptries for near vision. Handheld slit lamp is used to assess the centration of the lens. It is very important to ensure that the optical zone of the lens is centered on the pupil. Contact lens fit is not too tight or too flat. Usually try on different sizes to find the right fit. Regular checkups include slit lamp, intraocular pressure, as well as refraction and keratometry changes with age for next contact lenses. Contact lenses we are using. My personal experience in correcting aphakia in newborns started in 1997 when I attended clinic in Münster and courses organized by Walk company in Germany. At that time, Walk was manufacturing Silplex contact lenses for aphakia. These silicone elastomer lenses were the first to offer very high oxygen permeability, which made them suitable for extended wear and replaced every 3 months. Company Bausch & Lomb later took over the manufacturing of silicone elastomer lenses, Silsoft, which we have used for several years and prefer. But in the last year, Silsoft lenses are not available in Latvia. As solution, now we are using silicone hydrogel pediatric aphakic contact lenses Simplon from Ultravision company with wide parameter range, but these lenses are recommended for daily wear only and also to be replaced every 3 months. Questions for discussion. Considering the advantages of Silsoft contact lenses, extended wear and easy handling, we would like to ask, does anyone in Europe countries have access to Silsoft? And second, What else contact lenses are used for correcting aphakia for infants? Thank you for attention, and now I give word to next speaker.
Hello, my name is Vaida and I am a mother of a 4-year-old girl born with congenital cataract in both eyes. In the beginning, I would like to introduce you all to our Latvian community for families with children with congenital cataracts. We have a Facebook group and a chat, and approximately 30 families are members of this group. Some are more active, some are mostly quiet, as in all communities. But in general, I feel that it is a very safe and supporting space. We share almost everything, starting from our emotions and fears and ending with such practicalities as the best choice of sunglasses. Around half of the kids in the community were born with bilateral cataracts and the other half with unilateral. I would say that the split between the glasses and contact lenses is also approximately half and half. Most of the kids that wear contact lenses also have glasses as a backup. The main reasons for not using contact lenses are actually quite simple. Firstly, glasses are just easier. They're easier for parents to handle. And secondly, lenses, they get lost and they're quite expensive. The situation in Latvia is that we get state-funded contact lenses every 3 months. Lens type availability changes due to government procurement procedures and availability in the market. As Dr. Una mentioned previously, silhouette lenses are not available now, and the parents are just eagerly waiting for them. The experiences of dealing with contact lenses of the families in our community are just wildly different, and we would like to share 3 experiences as examples.
Hello, my name is Linda, and I will share the first story. I am a mother of talented and wonderful girl, Marta, who was born with congenital cataracts. Now she is 5 years old. We can say that our story with lenses is successful, since now all is good and we have successfully managed to adapt to all circumstances. But the beginning was not so easy and smooth. Marta had her cataract removal surgeries at age of 2.5 months and started to use her lenses 2 weeks after surgeries. At the beginning it was +30, now it is lowered to +21, and currently her vision with lenses with both eyes is 0.4. When we found out her diagnosis, it was shocking and devastating, but from the very beginning Marta was surrounded by professionals in Children's University Hospital, and their confidence, encouragement and professionality helped me as a parent to stay calm and be prepared to all possible outcomes and difficulties that might occur. Currently, we use silicone hydrogel lenses and remove them daily. It has become a part of our everyday routine, and Marta has adapted to process without objections. But at the beginning it was challenging. Her eyes were small and it was something completely new to myself. But with help of Dr. Una and support whenever necessary, we managed to train and adjust. To get to the point where we are now, when all lens insertion and removal process goes well, there was a lot of effort put, starting from educating myself to everyone around Marta, and persistency not to give up. From very beginning, I tried to make this process as less scary and dreadful to her as possible. Lot of talking, showing and involvement of her in the whole process. I let her be part of it, to touch, to understand the difference with lenses and without, and even let her choose when she felt that she would prefer glasses on a particular day. She knows that she's not the only person with lenses, have seen how others insert remove them, and feels confident that her situation is normal. Now Marta attends regular kindergarten when all her teachers and children know about lenses. She likes to tell and explain when someone asks for it. She also attends dance classes and enjoys her life and all small and big everyday tasks. And I know that my own determination and awareness of how every small detail and step can impact all her future life helped to come to where we are. I admire her, knowing how much she had to go through, and I am very proud of her. Of course, communication and ability to share fears, emotions, and experience was and still is what keeps me strong.
The second case we want to share with you all is my own daughter, Alma. She was born with bilateral congenital cataracts, and the surgeries were performed at 8 and 9 weeks of age. 1 week post-surgery, she began to use contact lenses, plus 32. Far vision with both eyes is approximately 0.25, sometimes 0.3. Near vision with both eyes is between 0.3 and 0.4. When we have silsoft lenses, which we order from USA when possible, we remove them weekly. If we have other lenses, then there is no other choice than to remove them on a daily basis. Sometimes she wears glasses. Alma actually likes them and sometimes asks for them. It is very convenient when she spends time with grandparents or other people. Alma attends regular kindergarten. Teachers are understanding, but I feel that they are a bit scared. They always call us immediately when there is a problem with her lenses. The very beginning was really hard for us. Well, she screamed and fought, and even as a baby, she was really strong. Breastfeeding was the solution we had when she was a baby. I inserted and removed the lenses only while breastfeeding. The solution afterwards, when the breastfeeding stopped, was unfortunately physical force. We had no other option. Her dad was sitting on top of her and holding her arms and legs while I was dealing with lenses. With her small eyes, lenses get lost frequently, and they were really hard to find. However, I would really like to advise other parents not to give up and keep on searching, because it is so worth it. I have found a contact lens lost in the garden between the raspberry bushes in the dark, and that was not the only case. Now everything is so much easier and gets better all the time. She tolerates removal and insertion quite well. She even asks for lenses when wearing glasses. Alma has recently even started to help in the process by lifting the eyelid. She can help herself if the lens shifts in the eye, for example, in the kindergarten, or irrigates it, and she knows how to ask for help. I'm really happy that now she's confident about being in lenses and also glasses as well. We as a family, I think we have worked quite a lot to achieve this. We have talked to her a lot about everything related to lenses and glasses, and we have read several books in English about kids with lenses, and she has a friend, Marta, that you saw previously, with contact lenses. She's a big fan of her eye doctor, Una, which makes the doctor's appointments just so much easier. So I would like to use this opportunity to ask all the eye doctors that work with children to take those extra couple of minutes to bond with the child, to talk to him, and just be nice and patient, because it makes a huge difference. We have also worked on her physical development a lot to build her confidence. She can ride a bike without training wheels, and she dances in a dance studio, and she is really proud of herself. In the end, I would briefly like to share my own conclusions and regrets that I have from this whole experience. First of all, I regret not enjoying the beginning of her life that much. I was really emotional and scared, and so I would like to ask the eye doctors to please encourage the parents of your patients and show them positive examples and share good stories. I also regret not starting with daily removal from the very beginning and not keeping a strict regime. I think it would have helped us in the later stages. And lastly, I have learned how strong and resilient kids are. Please push them and make them learn and do things, because they can achieve so much.
I will share another story of beautiful 4-year-old girl, Milana. Her family is also part of our parents' community. Her past is tougher, as there have been different obstacles with lens insertion and removal. Milana was born with unilateral congenital cataract and had her surgery at age of 5 months. First 4 weeks of lens usage, the insertion and removals were done at the doctor's office. But the process was long until the best lens fit was found. With her growing older and stronger, the process has become a real struggle, as she has quite hysterical reaction and fear from anything related to her eyes. Even mentioning lenses can create a panic. Now Milana uses silsoft lenses. but unfortunately those are hard to get. Lenses are removed monthly and it is done during her sleep. Any medical procedures, lens fitting, intraocular pressure measurements can be done only with local anesthesia, as impossible otherwise. Emotional trauma has created fear from other doctors as well. But now there has been a lot of improvements with her vision and attitude, so the tendency is very good. Thank you very much. It was a pleasure to share our stories, and we would like to thank also Doctors Una and Sandra for being so supportive and encouraging during our journeys.
Thank you very much, really cute children.
Thank you very much. And thank you, Luc, for your presentation. It was really very, very good.